Well, welcome to this session about health links and leadership. We appreciate you coming today. Just to get a sense in the room, how many people are currently involved in a health link that are here? So lots of people. This is great. So we're going to have lots of discussion at the end of this panel. So as you saw, our intent with this session was, one, to profile a little bit of what we're seeing and some of the progress that we've seen in some of the health links to date, but two, actually focus in a little bit on the role of leadership. So those are our sort of two main objectives, and we'll talk a little bit more about how we're hoping to do that in just a second. First thing is certainly need to just disclose that there's no relationship with any commercial interests of the four members of our panel that are here, or myself, I should say, and no commercial and no potential bias. So, and then again, just a reminder for those of you that like to tweet, to please, feel free to tweet today, and here's the hashtag. So just to begin, I think that, we're at a very interesting juncture with health links. I think that we've had a couple of years of experience. I think that certainly from the perspective of Health Quality Ontario, we've been very pleased to contribute in the ways that we have to date in helping to support some of the original health link teams as they got moving. And what we're seeing now is actually, again, a renewed commitment to continuing our work through health links. And this is a quote that actually came from the Premier's mandate letter to the Minister of Health, stating that through the health links, we've worked with providers across the system to deliver quality care in appropriate settings to our most complex patients. And you'll continue to build on these successes. It will be a challenging transformation, but you and your healthcare partners will work together to protect and strengthen our healthcare system. So I think what's wonderful, that is a commitment to it. And what it also does is, I think, recognize some of the leaders that have been sort of the early adopters around health links. Health links, again, are sort of designed, and we're going to hear a lot more about this, actually, from Nancy Naylor through the talk, but really some of the fundamental elements of health links were to provide really look at how we can shift the delivery of health care, look at how we're in the integration of services across that continuum of care, and really looking to support and champion the coordination of care and collaboration among providers. And with that, there's been a specific focus on improving access to primary care for seniors and people with complex chronic diseases, and reducing referral time from primary care to specialists, and ultimately improving the overall journey. So that's just in a nutshell. Now, many people here are involved in health links, so you actually know that, but I felt it was important to just kind of ground all of us. But really, this is a time for reflection. So we are about to start a new wave of health links. And it's a time to reflect on what we've learned to date, and see how, as we start a second wave of health links, how we can bring and help them to accelerate their own start as well. I do think one of the reasons why we wanted to focus in on this issue of leadership is that we know for any quality improvement initiative, or we know for any major change initiative, that the role of leadership in many different ways really is quite critical. Yesterday morning at the Ideas alumni session, we heard from Penny Whalen, who talked about adaptive leadership. She talked about adaptive work, which was about work that really is looking at reducing the gap between now and how we could be working. And that adaptive leadership is about actually how we approach involving people to perform that adaptive work and to work through that change. And we were reminded of a quote that, one of the common causes of leadership failure in these situations is that we actually think of an adaptive problem as a technical fix. And in fact, it's actually how we engage and work with people that is going to help lead to the success that we need. So that was part of the reason why we thought, really, let's talk about health links, let's talk about the progress we've had, but let's talk about leadership as well, because these are hard changes that we're working through in the system. These are just some aspects of what we think about when we think about visionary leadership. That can provide inspiration, can lead through uncertainty, create new partnerships, and ensure that services are patient-centered. But ultimately, this is really driving that culture of change. And I'm only going to, and with that, I'm actually not going to talk more. I've seen some of what's coming through the presentations of our panel, and I actually feel that each of them is really going to speak to this issue very well. So just to do some brief introductions of who we've got today on our panel. We've got, starting here, right here on my left, is Dr. Jonathan Kerr. He's a family physician and is the president of the Ontario College of Family Physicians. He's a primary care lead, and he's been very active working with the Health Links in Southeast Lynn. I was given permission to keep these short and sweet by the panel. Next to him is Dr. Tim Rutledge. He's the Chief Executive Officer of the North York General Hospital. Beside him is Nancy Naylor. She's the Assistant Deputy Minister of Health System Accountability and Performance at the Ontario Ministry of Health and Long-Term Care. And at the very end is Kirk Mason, who's a family member and a caregiver for his grandfather, and is a participant in the North York Central Health Link. So we're really pleased to have you all here today. They have many more ways that they contribute and many more things that they have done. But you can read they've told me that you can read their bios online. So with that, I think we will get started. And what we thought we'd do today, each of the speakers is going to speak for about 10 minutes about their experiences with the Health Links. And then after that, we're hoping for a discussion and dialogue with you. So we'll get started with you, Jonathan.
Good afternoon, everyone. Thanks so much for inviting me to be a part of today. Thanks to HQO and the planning committee. Really is an honor to be on the panel with these guests. And I'm really excited to be talking about something I'm very passionate about, which is Health Links and the topic of leadership. And in my view of leadership might be a little bit different than kind of what's in a textbook. I really like to think about leadership as servant leadership and really helping foster the development of other leaders across the LHIN. So I'm going to be talking about 4 key themes on how you might want to engage, motivate, and inspire others, specifically around Health Links. You can also use a lot of these techniques in your personal lives, your marriage, or anything else that you find useful, parenting. But these are the 4 key themes, and I'll jump right in. So a lot of people talk, these are my kids, by the way, Gwen and Tobin, they're 4 and 6. And a lot of people talk about communication, and what they're talking about is, talking to people and talking at people. And that's not communication. In the development of Health Links or any new complex adaptive healthcare system like Health Links, it's crucial to build relationships and trust between healthcare providers and organizations so that they, not you, they can start to finally communicate with one another and attempt to improve the healthcare system. And the only way to do this, and some of you might already be doing this, is to get out there and talk with people directly. Preferably not by phone, not by email, the dreaded email, but in person. This takes time, a flexible schedule, and for me, a lot of extra mileage on my car. What you don't want to do is invite them to your meeting at central headquarters or the LHIN office or the hospital. Go out and ask for an invitation to their meeting. And, what's really important is when you go there is to listen some more, and then listen some more. Your first meeting with a group, try to say as little as possible. At least that's what I try to do. Just soak up the culture. With Health Links, this meant for me traveling the region to see what it was like to practice in a rural family health team or an urban community health center. What issues were they facing, and how could I help? The whole point was to build relationships and trust before they were even needed. And as with any change process, there were a handful of people in each region that started to really get interested and started to get it. And with the Health Links context, that meant they started to want to talk about coordinated care planning. And so using the best practices from change management theory, when this happened, I pretty much ignored everyone else. I focused my 110% attention on those 1 or 2 people within each region that were interested. I supported them. I thanked them. I recognized them in front of their peers. I made it clear to everyone else that they made the switch and they were now part of this change process. I made it not about me, it was about them. Experts in change management call this practice focusing on the early adopters. And I know many of you have seen this slide before in some version. It was first published in 1957 by Rogers and his colleagues. And in any change process, there are different types of people. There are the innovators, those people that line up, 3 days in advance for the newest iPad. There are the early adopters, or those that follow close behind. There's the large group in the middle, the majority. And then there are the laggards, the ones that are likely never to change on the far right of the curve, and they will certainly be the most vocal, criticizing you and your ideas. So a common mistake that many leaders make, and that you have probably made, and I've certainly made in the past, is to focus too much of your attention on those that make the most noise. You will waste a ton of energy trying to convince the laggards to change, and they will still not budge. So instead, you have permission from me and from the change management theories to completely and utterly ignore them. Thank them for their time and spend your time with the early adopters. Your entire laser beam-like focus should be on the early adopters. The question is why? Now, this is a really key concept. Why do you focus on the early adopters? Because the majority, the large group in the middle, they don't follow those crazy innovators like you. The majority follow the early adopters. So by focusing your attention on them, by showing them off to their peers, making it clear that they have joined the change process, the majority will now see that it's safe to change. So with Health Links, this is the Southeast LHIN. In each of the Health Links, there were one or two or more individuals that quickly understood the necessity to change, and they were willing to help. These early adopters were supported, provided with strategies, tools, and encouragement. They were the ones, not me, they were the ones that brought others on board within their Health Link, using the pre-existing relationships and networks that they had. And because of this, and only because of this, they quickly drew others to the cause. In a few months, the number of Health Links in the Southeast LHIN grew from 1 to 3 to 5 to 7. A very, very rapid change process of a complex healthcare system over a large geography through a concerted effort to support the early adopters. Another key step in creating meaningful change towards HealthLink development was to create a sense of ownership by those that are affected by it. Notice I didn't say buy-in, right? I said ownership. What's the difference? They sound pretty similar, right? Wrong. Do you remember that really good idea that you had that no one followed? Any idea why? Because it was your idea, not theirs. You're simply trying to sell them something. And because people are naturally resistant to change, all of us are, they often aren't buying what you're selling. People don't like having change forced upon them. I don't, you don't, no one does. So in order to create lasting change, you have to try a different method. I suggest try fostering ownership instead. So what is that? Well, it's the single best way to get others to accept and even like change. If someone will be affected in any way by the change, get them involved early in figuring out what that change will look like. Consult widely, involve as many people as possible, departments, organizations. In doing this, I admit you will have to lose some control, and things might turn out a little bit differently than you'd imagined. But that's okay, because doing this will allow for a meaningful, lasting change. During the HealthLink evolution, we included doctors, nurses, nurse practitioners, case managers, hospital administrators, mental health workers, program managers, and most importantly, patients and their family members. Everyone was included, everyone provided input, and everyone feels ownership over the change process that's happening. As we sit here today, Health Links in the Southeast LHIN are doing the following three things, among others. Number one, they're identifying patients with the most complex needs, that 1 to 5% of the population with the greatest health needs. Number two, they're attaching these complex patients to primary care by finding them a family doctor or nurse practitioner. Number three, they're developing coordinated care plans with patients and their families to address all of their medical, mental health, and social needs. But importantly, in each of the 7 Health Links, they're evolving differently. They, individually, are deciding how to go about doing this in a way that makes sense for their community, their providers, and their patients. It's not the Ministry of Health or the LHIN telling them what to do. They are establishing the right solutions to create and enable change across their own health link. They are involving patients and families in ways that make sense to design and evaluate their health link. They haven't just bought into health links, they have ownership over the health link. and they're driving healthcare system transformation faster than we could have imagined. Alan Chong, I see at the back here from Rural Hastings HealthLink, and we've seen amazing results. 86% reduction in emerge visits for their HealthLink patients, the most complex patients. 88% reduction in admissions to hospitals. Amazing results. The last thing that we do is we're really trying to involve patient stories. And once we started seeing some early successes, like I just mentioned, it's really important to use and for you to use patient stories to bring others on board. As the saying goes, hit them in the heart, then hit them in the head. Let me tell you quickly about a patient named who I'll call Darla. She came to my practice, she moved from another city, and she was really, really sick and had a lot of medical issues, a lot of social issues. She's very, very poor. And as we explained the HealthLink concept to her and had our care team meetings, she wept. She broke down in tears in my office and said, finally somebody is listening to what really matters to me. Finally somebody is really in my corner. And champions in each HealthLink gave a similar personal story about one of their patients, and they would get up and talk to their peers and colleagues in a family health team or a CHC. And we also gave them these slides as well to use, and to give them a slide deck like this. A family physician might use something and explain to his or her colleagues how it's easier to obtain healthcare services for their patients, how they feel better supported managing their care. And most importantly, we also explain the benefits to the patients. We tried to bring the patient voice in as much as possible, using quotes and stories and patient panels to explain how this has made a difference in their life. Fewer visits to doctors and hospitals, higher quality of life, and they feel supported in managing their care. So these are just some of the examples, the 4 methods that we use in the Southeast LHIN, and I'd be happy to take some questions afterwards. Thank you.
Thank you very much, Jonathan. So this is one of those moments. Did you all hear Joshua this morning when he said that he embraced failure? Because I've just had one of those moments with this panel. So the team here had me very organized to be sure I had the order of our speakers appropriate for this session. And I have already made a mistake with it. So thank you, Jonathan, for going first. He was anticipating going second. And now I would like to invite Kerr to come up and provide the perspective from a patient and a family member.
Hello everyone, I'm glad to be here speaking in front of you all today. 2 years ago, if you asked me, I definitely would not have thought that I would be speaking in front of such a large audience, and definitely would not have been thinking about being in the healthcare system. My journey started 6 years ago when I decided to go to Toronto for university. My grandfather was pleased enough to have me come and live in his house. And sort of just do a little bit of chores here and there and help out. This went quite well for quite some time. I developed some cooking skills and helped him out around with meals and so forth. But 2 years ago, it was actually Boxing Day. We were at my parents' house and he suffered a fall. He stayed at my parents' house for a day and a half, complaining that it was a little uncomfortable for him, but he was a British man, and if you don't know anything about British men, they have an extremely stiff upper lip. Turned out he had actually fractured his hip, and he sat on that for quite some time, no pun intended. We took him into the hospital, and they scanned him, gave him some medication to deal with the pain, and basically put him in through surgery. He woke up, and no complaints about the surgery. Felt great. Couldn't believe the advances that we'd gone through to this day. A couple days later, he was still a little hazy from what we thought was the sedation. And after a few more tests, it turned out that he had developed COPD. So this was just a little hitch along the way. And he would be in hospital until he was good enough to go home. He eventually was discharged, brought back here to Toronto, and I became his caregiver. Both of my parents are physically disabled and were unable to really step up to help him. And so that's why I decided to help him in his moment of need, as he had helped me 4 years prior in my moment of need. From there, it was a very difficult journey through the system, because I was just some young guy trying to figure out what was going on, and he was not really capable of doing so himself. Being part of the older population, he has a good understanding of technology, but he didn't really have the know-how to find the services he needed. He would go for the yellow pages that was, maybe up to date, maybe not, and we all know how much information you can get from there. So as our journey continued, he didn't really do too well recovering from his hip injury and his hip surgery, and developed somewhat of a depression. We don't know how long that would have taken for the system to find out, because I was the one that actually brought it to the system's attention, having studied psychology for the last 4 years. I was very well versed in understanding what the signs and symptoms are, and I brought this up as a concern, actually after we had visited a doctor's office. Now, although that doesn't seem like much, if he was coping a little bit and was still having these symptoms of depression, that wouldn't have been caught right away in the system. From there, he went on to some antidepressants and continued on that journey, slowly trying to become better. When someday in April, he woke up in the middle of the night with heart pains. We scrambled around, called emergency services, brought him into the hospital, and it turns out that he had heart failure. So as I'm sitting there in the hospital waiting for him to come out, or someone to come out to talk to me or tell me what's going on, I'm filling out paperwork for the nth time, entering in all the same information over and over again as to, the fact that he has diabetes, the fact that he has depression, the fact that he has X, Y, Z. And I thought there must be a better way. There must be a better way to sort of get this, because if he had just woken up, called, and didn't have a grandson living with him that was able to travel to the hospital, then I don't know how they would have gotten that information if it needed to be filled out. Afterwards, he came back out, and I brought him home and got him settled in. And shortly after that, he began developing hallucinations, and he started getting memory problems, and it went severely downhill from there. After a few trips to some specialists, we eventually arrived at a neurologist up in North York, and he was great. He interviewed Granddad, had all the proper questions, and was very thorough with him. But after he finished his conversation with Granddad, he walked Granddad and I down the hall, and I passed him a note. The note said, "Please bring me back to your office." So we sat down Granddad, and he told me that he forgot some paperwork in his office that he needed me to fill out, and he brought me back there. And that's where I told the rest of the story that Granddad was unable to tell. Due to the fact that he had memory issues, he wasn't able to properly relay all the information that should have been relayed to the specialist in order for him to get a clear understanding of what was going on. Through the tests and through all of the scoring procedures that they had, they were able to get somewhat of an idea, but they were unable to get a full physiological idea of what has been going on with this gentleman. And it was great that he was able to do this. And, you know, it was a bit of a gray area even for myself to do this, because it felt terrible to have to request it. But I felt it was something that needed to be done for his care. And so that was one aspect of the journey that really sort of shed some light on the fact that your client can be more than the patient. And when you're in the healthcare system, your client can actually be much larger than that one person sitting in your office. So as we continued through the journey, he developed an infection due to one of his falls and ended up having to go into retirement care. And finally, through large wait lists, was able to get into one. I wish that I could give a better ending to the story, but he passed away shortly after he entered retirement care. So while I was caring for my grandfather, I was brought on to the Health Links initiative to help the system that I was still navigating at the time. Although my story is a difficult one, and one that is not a story of necessary success in the system, it's definitely a story that you can understand some of the pitfalls and understand some of the ways in which we can look to improve or gather better data or get a better picture of what's going on in the home. I myself am really glad to be part of the Health Links initiative because I'm able to change people's journey through the system and improve the experiences that they have. Because as a 23-year-old living alone with his grandfather, working a part-time job to pay his bills for his own schooling that he had to put on hold to care for the grandfather, I was in a very difficult position to be a full-time caregiver for him. I had about 3 hours a week from a caregiver, and that was all that was sort of determined to be necessary for my grandfather's care. One of the major pitfalls in the system there was the fact that my grandfather had to have four courses of medication throughout the day. And if you're working a part-time job, it's kind of difficult to be home to make sure that he does it. The PSWs weren't allowed to administer medication, but were allowed to remind them to take medication. But as people with any sort of dementia are known to do, is not necessarily heed people's advice who are strangers in the home. So I guess what I want to say about that is that we need to shift the way we view things to a more holistic view of what goes on at home. Because it's simple to say that they're getting the care they need in terms of day-to-day, but when somebody has to go home on their lunch break to make sure that their granddad takes their medication every day, and that sort of level of care for the patient or client is there, but not necessarily there for the family. I just want to leave you guys with one statistic I found was interesting. According to the OACCAC, 5% of Ontarians account for 66 of Ontario's healthcare expenditure. That's a huge amount of expenditure for a small amount of people. If we can work to keep these people at home and to keep them safe, and can keep the people that keep them safe and healthy, that is a way that we can sustain the system. And without that, all of these pitfalls can lead the system into a very tricky, difficult area. Thank you.
Kirk, thanks so much for sharing with us that story. It certainly highlights how our system is not optimally organized right now to meet the needs of patients with complex issues, and highlights the opportunity that we all have here. And that's what HealthLinks is all about. Good afternoon, everyone, and I'm pleased to be here and share some of the learnings that we've had at the North York Central HealthLink. The first point I want to make really builds on points that Jonathan was making about the importance of us learning about complex patients and designing HealthLinks in a very collaborative way. The North York Central HealthLink is truly a partnership. These are the 4 organizations that came together to initially design the project. In fact, my leadership in the whole thing is actually of relatively small importance. This was truly a co-creative effort, and I think that is a key secret to success. People tend to commit to what they create. And by the way, when you use that learning organization approach, where you respect the expertise of the folks that you're bringing to the table, your product is going to be far better. You've got all the necessary brain power that you're going to mobilize and harness in putting together the project. So the partnership approach, the learning organization approach, the co-creation, I would say, is a secret to success for our HealthLink and any other HealthLink. These are the 4 original partners. They are the North York Family Health Team, which is a big family health team very close to North York General Hospital. We serve basically the same communities. There are 60 family physicians and a number of allied health professionals working in that team. We certainly benefited hugely from the significant engagement of the Central CCAC. And by the way, all of these organizations were involved from being at the highest levels, and folks that were actually doing the work at the front line provided a lot of the creative. North York General Hospital, and then the other was Toronto EMS, and they continue to participate and provide some neat ideas, and I think that there'll be a real valuable role for EMS in HealthLinks in the future. This is just the core partners, but as we got busy with this, as we started to enroll patients, we started to develop lots of really fruitful partnerships. So we've engaged and worked closely with a number of community support agencies, which include, but this isn't a complete list, Circle of Care, the North York Senior Center, Better Living, Loft, and mental health agencies including Toronto North Support Services and CODA. And as I say, we continue to bring on other agencies to help us care for these patients and optimize our HealthLink model. This is a quick look at our process. It probably looks similar to other HealthLinks. We are now identifying patients from multiple providers in the system. Some of them from our inpatient units at the hospital, some from the emergency department, from the primary care providers, as well as community services, and EMS is also identifying potential patients. And we use a number of patient identification tools to try and get a handle on just how complicated they are. So you'll be familiar with the LACE score. We look at numbers of admissions, numbers of ED visits. We also, in the primary care, we use the PRA score, and the DIVERT score in community services. So we initially went into this thinking that we were going to come up with one way to quantify complexity, and what we found in practice is there's real value in using a number of different ways to identify these folks. So the patients are referred from any one of these sectors, and then they are contacted by one of 2 HealthLink care coordinators. And these folks are care coordinators from the Central CCAC who have focused in on HealthLinks. They do intensive care case management. And so they contact the patient and their family, let them know about the opportunity, and engage them. And at that point, they actually start the coordinated care plan. They start to populate some of the data in that. Then they get in touch with the family physician, And together they talk about the case, what the needs might be, and based on that conversation, they decide who should participate in the case conference, which is usually a multidisciplinary case conference. It involves at least the patient and their caregiver, family members, primary care physician, and the care coordinator, but may involve other practitioners, often does, specialists, physiotherapists, pharmacists, as the case may be. A really key part of this engagement or this case conference really is the patient and the family. And what we found is patient goals are critically important. I mean, the medical model has goals that they're going to want to accomplish, but sometimes they're not exactly what the patient and family want, and the patient and family input is critically important. The product of the case conference is the coordinated care plan, and that's where all practitioners are going to work off that and implement the plan to care for these patients. And then if things change down the road, there's always an opportunity to go back and hold another case conference. What's missing on this is the exit criteria, or I should say, what's at the end of this process. Not all of our cases are ongoing, so we've enrolled nearly 200 patients now, and about 50 of them have graduated from the HealthLink. That is, they have reached a steady state and no longer require the services. Of course, they can be reinitiated later if necessary. So that's just a sort of a bird's eye view of the process. Our HealthLink model is a patient-centered, team-based model that aims to provide comprehensive, continuous, coordinated care to high-needs patients with the goal of optimizing their health status. So it's very much aligned with the concept of the patient-centered medical home. We have really benefited in our little system from deep engagement of the family physicians in the Department of Family Medicine at North York General Hospital, the family health team. They've provided a ton of really valuable guidance as we proceed with this. And we have a very, very engaged Department of Family Medicine at North York General, 300 members of the department. Of course, it's those folks that are the thought leaders and the designers in the early stage are the ones that are really committed off the top. Then you need to go out to those other 300 and beyond, because there are another, I think it's 500 family physicians in the catchment area that we serve that need to be brought up to speed with what HealthLinks is trying to accomplish and what their role might be. And it goes beyond family physicians, of course. We need to bring up to speed the specialist physicians as well. So we've used a number of venues to educate docs, to help them to understand what we're trying to accomplish, what are the benefits, how they participate, how to bill for HealthLinks patients, how to refer to patients. And so we use a number of existing structures. We use departmental meetings. The Department of Family Medicine has regular rounds at our hospital, and we make announcements there. We also use the Medical Staff Association meetings. We have had lunch and learns in some of the family practice offices. Our physician leaders at the hospital are very much up to speed with this, and we've used our MAC and clinical chief meetings to talk about this. And so the physician leaders are up to speed with it, and then the next step, of course, is they need to impart this information onto their various departments. This is before HealthLinks was announced. We had actually done a deep dive strategic plan at the hospital, and you'll see that we've actually been able to springboard off of this strategic plan because HealthLinks seemed so well aligned. In fact, that's why we were interested right off the top. You'll see the headline of our values is that patients come first in everything we do. In fact, for the last 2.5 years, we've been on a quest to really patient and family-centered care into the fabric of North York General with a fantastic Patient and Family Advisory Council. And so that's part of this. But there are a couple of other pieces. You'll see that there's a key strategic direction, which is excellence in integrated patient-centered care. And within that, we had an initiative called Connecting Care, which involved a number of things that was designed to help us communicate better with the family physicians and other physicians that had patients that we cared for in the hospital. So we're doing fax notifications to now over 800 family physicians in our geography. Fax notifications about ED visits, admissions, discharges, deaths. And now we've actually started doing those fax notifications for admissions and ED visits to our case coordinators at the CCAC. We have implemented warm handoffs, so that involves providing cell phone numbers for family physicians to our specialists so that they can contact them when they're discharging complex patients, which really helps to facilitate health links. We created a physician directory, which is really an inventory of how the family physicians can get in touch with our various specialists. And in that inventory, in that catalog, it lets them know what the subspecialty areas of interest of the different docs are. So I can tell you there's a ton of enthusiasm in our steering committee, our HealthLinks steering committee, and we really definitely want to see this carry on no matter what happens. In fact, many of the things that we have learned and implemented for HealthLinks patients have had benefits to other patients who aren't HealthLinks. So this degree of collaboration and cooperation has been fantastic. We had, and so to this end, we had a sustainability forum just a month ago where we looked at our successes, we looked at opportunities for improvement, and we talked about strategies to sustain the gains we've made. And these are the sort of four realms of what we came up with. We currently like our governance structure. The steering committee happens to be co-chaired by Jennifer Bowman, who's our Vice President of Clinical Support Services, Strategy and Integration, and our Chief of Family Medicine, Dr. David Eisen. But as I said before, of course, the other partners are key members of the steering committee. So we'll continue that structure for now, and however it evolves, it will support the ongoing evolution of this integrated care model. Physician engagement is absolutely critical, so we continue to have efforts to reach out to the docs, the specialists, and the primary care docs to help them to understand what we're accomplishing and engage their thoughts on how to make it better. We've accomplished we've forged a lot of really active partnerships, and we'll continue to increase those in quantity and quality. And we know that a key to success going forward is really to optimize our information sharing and connectivity, and so we will certainly be on board with those initiatives as they proceed. So in closing, I think keys to successes really are this concept of creating a collaborative culture. Leadership is key, distributed leadership in all of the partners. This is focused on the needs of patients and their families. When we think about integrated care, we think about integrating care of all the providers, but we also think about integrating the patient and their family into that circle. The other sort of key for us that we found very helpful is just do it. This is a very complex process. And very complicated patients, and you learn with each one. And if you try to get it perfect off the top, it ain't going to work. So just get going and tweak as you go, and I think that's really been a key for us as well. Thanks very much for your attention.
Well, thank you very much. And I'm Nancy Naylor. I'm from the Ministry of Health. And I think I'm batting cleanup and probably catching up a bit on time so that we have time for questions. But when Lee asked at the beginning for a show of hands about how many people were involved in HealthLinks, I think half of the room put up their hands. So the first thing I want to say is thank you for your leadership on this. I also want to say I'm here representing Helen Angus, who's one of our associate deputies, and she was very instrumental in the beginning. Although Helen would be the first to say she adopted Jonathan's model of change management, which is, how about this? And the response that was, came back was very positive. I do want to share one observation. I'm relatively new to the Ministry of Health. So the first time I heard about HealthLinks was when Helen came and spoke to us. I was a member of the senior management committee at another ministry, and it sounded like a very intriguing idea. And one of the phrases that she used stayed with all of us. She said, we're going to do this, and we're going to do it in a low rules environment. And I know, my guess is that was probably part of the appeal for many of you as well. The idea that we were going to try something this ambitious and yet this logical, but we were going to try it with low rules, and we were going to see how people took this idea and went forward with it. And so I just want to say, as ambitious and as interesting as the HealthLinks initiative is in the health sector, it's very, very interesting from public administration's perspective generally, and there are people in other sectors who are watching HealthLinks and finding this very interesting. So, all right, let's start. Whoops, here we go. All right, so as Kirk helpfully pointed out, the beginning of HealthLinks was really started with the observation that 5% of our patients were incurring about 66% of our costs. They were accessing on average 6 or more physicians, with many of them accessing 12 and 16 or more. So clearly there was a cluster of high needs patients, and ISIS did some of the early research to identify those clusters. And once this idea was proposed with the announcement in November 2012, things started very quickly. So by July 2013, 26 HealthLinks were up and running. By March of this year, 54. We signed off more this summer and this fall, and we are heading towards 90 plus. 98 is our goal, because that reflects the number of clusters that our data identifies across Ontario. We have HealthLinks in 13 of our 14 LHINs, with all of our LHINs participating. In terms of early wins, the HealthLinks that have been established so far, and we have 67 in operation, have attached 8,200 unattached patients to primary care physicians and developed care plans for 3,200 of them. Over 1,000 partners from the health and social service sector are involved. We are thinking, and Helen has people on her team who are thinking about the maturity journey for HealthLinks. So we are conscious that we're in the early stages. We want to make sure that we're progressing at a pace that's responsible and reasonable. And even Tim tugged my sleeve and said, don't rush us on this journey, which is good advice. But I think one thing that our Deputy Minister, Bob Bell, has said from the beginning, from about 10 minutes after he arrived, he's right, all right, HealthLinks, what's the next stage? What's our plan to support this important initiative as it goes along? So there are smart people thinking about this, and they'll be talking to you. So the HealthLinks team also, even in the early stages of this, commissioned a rapid cycle evaluation in last fall, I believe. And this gave us some great feedback, gave us some feedback that we were on the right track on in a number of ways, but also some of the tools that people were identifying that they needed to get to the next stage and to broaden their reach with the high need patients. In terms of feedback from that, so tools that the sector has asked for, a complex care tool across the province, which we're building now and building out to make available, flexible funding as we go forward for maturity. So my part of the ministry gets the business cases. We're seeing new versions of how how people would propose a HealthLink would work, what kind of patients would be involved, what kind of providers. So, we're happy to be flexible. We have some questions. It's taxpayers' money, but I think we're seeing, variations on the original model. It's definitely not a single blueprint. And we're working towards a maturity strategy with an advanced HealthLinks model. Part of that would be, what is the governance structure or the governance model for HealthLinks in the long term? We are working on performance management indicators with people who are actually running HealthLinks right now, and thinking about best practices and how to promote those. And finally, I'm going to stop here because I will mention, I think many of you would have had a chance to see Minister Hoskins speak at lunchtime. I think following these sessions, our Deputy Minister Bob Bell will be speaking. Both of them would be touching, and I think Bob in particular will be talking about how we are translating the mandate letter that we were given by the Premier. Lee mentioned it at the beginning. If you haven't seen it, it's a fantastic document, and it's a little bit revolutionary that we're actually making mandate letters public. There have been mandate letters for a while in government, but they tended to be confidential letters between the Premier and his or her ministers. The idea of making them public, why not? We can all see them, and it's actually quite extraordinary how leadership in the health sector is looking at that and saying, how do we align our business plans with this? If these are the priorities, let's line up behind this. So fantastic. But Bob will talk about the priorities identified in the mandate, how we are going to translate those into actual work plans. So you will see things like the redesign of home and community care as a big priority. You'll see things like integrating integrating care for patients as a big element in that. And between the loftiness of strategy and the pragmatism of work plans, where HealthLinks comes in, the word we use for that is our ground game. HealthLinks is the ground game, right? So if we can create the patient experience we want for the most complex patients, the system, we will learn from that to make the system work for all of the patients it needs to serve. Okay. So I'm going to stop here. Thank you.
Thank you very much. I think that really provides us a nice overview of some of what we're seeing. And actually, I think a really nice representation of the true spirit of HealthLinks and what we're trying to accomplish. Starting from engage early, engage where people are, rather than trying to kind of bring people together. Kirk, I think that your story and now your willingness to actually contribute that back to help the HealthLinks sort of form in a way that is a much more holistic view of what the needs of patients and families are is incredible. I really feel it. Again, I think, going back to Nancy's comment just now about sort of the low roads, I mean, this is the spirit of what the HealthLinks were originally about, and then, some of the advice and experience that we had from Tim about, again, one, just get going, I think is a very practical insight. But also, that we've got to think about the fact that this is changing the way people are planning to do things and acknowledging there are changes for providers in different ways and being cognizant of what those are. And, you did say, helping to bill for this. I mean, those are some of the it's sort of understanding the change from each member's perspective in providing that. And finally, Nancy, I think it's inspiring to think that we're going to still keep working away at HealthLinks, that they are going to be evolving. Again, fascinating to see it being seen as a bit of a new way of doing policy as well, and wanting to learn through that as well. So thank you very much for all of those insights. I've got a couple of questions here, but I wanted to first look to the audience. Are there some questions that people have got? Mm-hmm.
Hi, thanks very much for that. That was just an extraordinary session. Really enjoyed it. And so we heard this morning the eloquent story about the Alberta situation, Greg's story. And we heard about the wonderful grandson story. And as I listened, I tried to see how HealthLinks would have picked him out of the river. And so I'm wondering, as we think this through, I heard a lot about referrals from physicians and providers. Is there a place for patient self-referral?
Great.
Well, I think it's very important that we do have, as you probably heard at Dr. Hoskins' talk, a no wrong door policy. I found a lot of the difficulties maneuvering the system were going down a path, one or two or three doors in, and then realizing that it was the wrong way, and that could be, hours of work, or it could be days and days of waiting for referrals to flip back and forth. So self-referral is very, very important, I would think, and that we have a larger conversation with those involved to see where these referrals should take place. Because in my situation, my granddad would not have either had the gumption nor the idea to go ahead and seek out a neurologist. And I, having taken a psychology degree, would barely have that idea to go ahead and do that. I wouldn't even know where to start to try and get a referral. So, we had to sort of work within the small world that we knew and understood. And I guess the bigger aspect than self-referral is creating a system that allows various opportunities for various people to become involved and to intervene, or to open up those first doors just a little creak to see what's inside.
Great. Thank you, Jonathan. You
Just to
wanna
quickly
comment?
touch on this, let's just be really, really clear about what HealthLinks is attempting to do in the early stages. So there are millions of patients in Ontario, and I'm sure they would all love to be a part of this. HealthLinks is really focusing on the 1 to 5% of patients in the early stages. Eventually, I agree, HealthLinks is going to evolve into something bigger. But initially, the 1 to 5%. So, for example, at our hospital, we said, hospital system, could you please give me my list of high users? So I got a 9-page report of all of my patients and a year expenditure of their care. And so for 8.5 pages of it, it was like really small, like $100 or $1,000 for a woman that just had a baby, or something like that. Very small expenditures, relatively speaking. 4 of my patients, just 4, had $500,000 between them. And the rest were like very small amounts. So, I know who my 4 high users are. That's who we started with coordinated care planning. If person number 10 on the list, who had $1,000 of healthcare expenditure, wanted to be a part of this, we'd actually probably respectfully decline and say, at this point, lucky you're not a complex user. We're focusing on those 4. And if all the family doctors in my town, we tackled those 4 patients for all of us, or 10, or however many are in our practice, that's where our focus should be. Again, Kirk mentioned the stats. 2/3 of the healthcare dollars spent on 5% of the population. That's who we're going after. That's where the real change in motivation is. And we start seeing the stats, the 88% reduction in readmissions and emerge visits out of these HealthLinks, we're going to start seeing the cost curve shift as well.
I'm very sorry. I should have been more specific as well myself. Having a coordinated care plan, or having a discussion around his care with various professionals, it would have become very apparent that we needed a strict plan put into place in terms of medications, because he had so many various symptoms, ailments, and other disorders that sort of came about through his healthcare journey. And so, yes, the statement I made earlier would be great, and sort of, hopefully you can take that away and think about that and see, what you can apply that toward. But in our case, the tools in the HealthLink system would have been greatly beneficial to, first of all, see that he was having tons of contact points within the healthcare system in various different areas, to then pull that and realize, hey, this guy uses the system, once a week in a different facility. So then that would have been sort of a red flag as to, okay, this guy would be a high user of the healthcare system, and then from there coordinate a healthcare plan to make the flow a lot easier throughout the system.
Great. Thank you. Got another question over here.
Hi, my name is Sarah Urowitz. I'm the Program Manager for Palliative Care at Cancer Care Ontario. I'm also very involved in provincial strategy right now in terms of implementing our provincial palliative care strategy, the Declaration of Partnership. And as as we work both within the malignant and non-malignant disease worlds, we've looked a lot to health links and really trying to understand how we can either leverage systems already in place or learn from lessons. And we talked a lot about this 5%. Evidence is telling us now that 1%, those 4 people on your list, would also benefit from earlier identification of palliative needs and earlier delivery of a palliative approach from primary level providers like yourself. So it's of great interest to me to hear your thoughts on how we might leverage lessons learned for health links or work together to really advance some of the OTEC recommendations for interprofessional care and better provision of palliative care.
Great. Who would like to?
I'm happy to speak to that. I mean, so I agree completely. One of the things that we've seen out of the 7 health links in the Southeast, 4 of them have created a separate working group for end-of-life care, and they're all involved in this. Again, it doesn't really matter how you get to it. I like, the way Tim did it, all these different scoring systems. It doesn't really matter how you get to who those complex patients are. But one of the criteria that we have in our 7 health links is any newly diagnosed palliative care patient. They automatically get rolled into this coordinated care plan process. And for those of you that have seen and worked with the tool, the coordinated care plan tool, there's a very clear section there in advanced care planning, end-of-life care planning, to make sure that their wishes are fulfilled. And what we've seen actually, and I don't think this is all due to health links, but I think partly, we've seen a huge drop in Quinte Healthcare in the hospital in Belleville, a drop in the number of patients dying in hospital. That's tremendous, and we've seen that in the last year. So I think this is a really key area. The overlap is nice. It forces the discussion between care coordinator, patient, and physician, and family, also importantly, about goals for end of life. I want to be at home, et cetera, et cetera. It's a great process, and I think the overlap is huge. And the cost savings are huge. Better quality, better cost outcome. People dying in their own home where they want to be.
I'll just add a couple of things. First of all, a number of those patients actually meet criteria for health links. The other thing I would say is that we're learning a ton from the health links processes that pertain to all kinds of other patients who wouldn't necessarily be health links by our current definitions, and there's no reason why we can't put those things into place. We're forging relationships between CCAC and primary care that didn't exist previously, so there's no reason why those relationships can't pertain to other cases. The final observation is that we're finding end-of-life discussions are a key learning that need to occur with almost every health link patient in a sensitive way, and as you well know, that takes a lot of education, sensitivity, and so I think as health links mature, we're going to get way better at the kind of care you're talking about.
Great. We look forward to maturing it with you.
Great. Thank you. Question over here?
I'm sort of an interloper here in some ways. I'm a lawyer and I'm a patient advocate, and I deal with the problems that arise when the law isn't followed in the health system. And I think Health Links is terrific, but people are sharing with me in my office, I'm from the Advocacy Center for the Elderly, many of the Health Links forms, and we see deeply flawed forms which are going to lead to problems. So not getting proper consent, it's not patient-centered in some cases. I had one clerk said it's his job at a health link to ask people if they're DNR. And I think that's totally inappropriate. The clerk had identified that. So that the sensitive conversations about end-of-life care were taking place in the wrong place. But a lot of it was being driven by the forms. And we're seeing the embedded misunderstandings about consent and advanced care planning in a lot of the forms. So I'm going to say this as to encourage you, because I think Health Links is fabulous. And a lot of my clients are Health Links patients because of their age. I only act for older adults. And but I would encourage you to get some really good legal reviews, because we are seeing things really embedded that are going to cause problems at some point and are reinforcing what could be poor practices. And I know that's not the intent. And as soon as I talk to people, they go, "Oh yeah, we're not getting consent here. Oh yeah, we're just doing a tick box form." So
Okay.
Anyways, and we've written a paper for the Law Commission of Ontario. If anybody wants the links to it, it's on the Advocacy Centre for the Elderly website, and it's a 345-page paper on healthcare consent and advanced care planning, and a lot of these misconceptions.
Great, thank you. Does anyone want to respond?
I just
Yeah.
want to say thank you for
Thank
those
you.
important points, and let
Yeah.
me revise my last piece of advice. Just do it carefully.
Carefully. yeah, exactly.
So I'd be
Exactly.
interested in learning
Yeah.
more details. We
Yeah.
know that secure communication and engaging the appropriate personnel in the circle of care in those discussions is critically important. I'm hoping that there aren't those inappropriate communications happening with My Health Link, but I can't promise you that they're not. So that's great wisdom, and we need to look at that carefully.
Lee,
Yes,
can I have
Jonathan,
permission
please.
to be a little controversial here?
Sure.
Awesome. Is the
Always
group
welcome that.
okay with that? So thank you for the comment. Certainly, I haven't seen that in our health links. You know, what we're seeing is patients and families loving this process. I mean, now they come to a community case rounds with all of their providers in the same room. You know, whether they sign something or not, and in our health links they're signing a consent form that says everyone as part of my care team can talk to each other and be involved in this process, etc. Very, very simple form for them to sign. But patients are loving this, and providers come to me, and especially some of the doctors who are worried about perhaps, you know, the legal ramifications of this and sharing care of their patient, and they don't have control. You know, I try to ratchet down that fear, right? So let's not make this a fear-based process. This is about the best possible patient care, involving patients and their families in their care. Yes, there'll be the odd consent form that they need to sign, very important. But if we're doing this from the right place in our hearts, in our minds, we can do this well, and we shouldn't be afraid of it.
Great.
I
Okay.
was gonna say, consent is not a form. Consent is the exchange.
Exactly.
Yeah.
We're hearing that people aren't getting necessarily the exchange.
Yeah.
That's why.
That hasn't been my experience.
Yeah.
Yeah.
Okay, that's great. Thank you. Question?
Yes. Hi, I'm Deb Egan, and I'm with the West Toronto Health Link, just approved, so looking forward to following in your footsteps. Wondering from your experience if you have any observations of things in the system that we would stop doing as a result of health links being in place, because we're very good at adding new programs and new layers, but what do we take away because health links is now in play?
Good. That's a good question.
Fantastic question.
Yeah,
The only problem with it is that it takes a lot of thought.
yeah.
What would you
So
suggest?
maybe the next one.
Well, can I take a stab at that? Sorry, I talk too much, folks. So when our health links started, again, we were primary care-led health links, the 7 of us, 7 health links. And, you know, we're hammers. We like to pound nails, right? So great, health links, let's build more programs. We're going to have a COPD program and a CHF program and an Alzheimer's program and all of these programs. And then we got a little bit through the planning days, and we said, let's take a step back. Let's not keep doing what we've always been doing in family health teams and CHCs. Let's do something differently. Let's reorganize maybe our programs. Let's shift resources from these very highly intensive programs that may or may not be working, we don't know, and try this innovative approach. So what we're doing is reorganizing within our family health team. Our social workers are spending more and more time with our most complex patients, and we're actually reorganizing and doing less of what maybe didn't work in the past and more of what did. The other thing is, I think the partnership between hospitals and primary care is something we need to keep doing more of, and Tim's hospital is very open and engaged with their primary care. I think we need to do less of the kind of us versus them mentality, community and hospital.
Great.
So I haven't been able to come up with any big ones, but certainly if we do this right, there will be decreased use of inappropriate use of emerge departments, avoidable admissions. I would think we'll be avoiding long waits for inappropriate consultations because the care providers have collaborated on an optimal approach for a given patient. But there are probably other things, and it's a really great question that we should be pondering as we mature this model.
Yes.
The other thing I'd add is I don't spend 15 minutes now with those 4 patients. Like, my receptionist knows if Mrs. Jones, I'm making up the name, calls, like she gets 45 minutes at least, right? So those 4 patients now, high alert, we are really spending more time, I'm spending more time personally, and our team is, with those patients, and stop the old traditional family doctor booking system that everyone gets 5 to 15 minutes. So those most complex patients get more time.
Yeah, I think we just need to challenge ourselves, because more healthcare does not necessarily mean
Right.
better health. And so I guess the more we can think that way, and I don't have an answer either, that's why I'm asking you, but maybe we'll have some answers next year.
That's great.
I think that something that would occur if you were to, put this into play is not necessarily you're going to be doing less. What can we pare out of the system or off of the system? But if you were to take an example of my grandfather, we would have various discussions back and forth through different professionals. Should he drink more water? Should he drink less water? Should he have water pills? Because he had cellulosis, but also a heart condition, but also he had an infection. And so it becomes very, very difficult. So the fact that he used the system over and over and over again, going to different professionals and getting referred back and forth because he had weight gain, weight loss, he had, huge issues stabilizing his blood pressure. And so it's not necessarily what your professional or your profession is going to be doing less or not. It's more so what interactions are not going to have to take place. Instead, you would sit down, hammer out a plan, everyone would be on the same page. Hopefully everyone would be happy with the decision, but there would be one decision, and that's the end of it. They would come back and review it if things were to change or, after a certain amount of time, but there wouldn't be a rapid change of pills and regimen that he would have to go to 4 or 5 different professionals to, finally get the answer. And even then, we're all sort of looking around, hoping that maybe this is the answer, maybe it isn't. I don't know. Next time we go to somebody, they'll have a different answer. We'll just sort of leave it. I don't know. So, it's more of a systemic or interaction-based less than it is a program or resource less.
Great, thank you. I think we're coming near the end of our session. Do people want to hear one more question? We'll finish just a few minutes.
One quick comment back to Deb
Sure.
on the question what we would be doing less than more, because I do agree it's a great question. I'm Tia, one of the family physicians for the East Toronto Health Link, and a strong advocate for health links and my patients, and I've already noted what I'm doing less. For example, I'm doing less calling around 5,000 different people who I need to coordinate care with, because I haven't quite figured out yet when was my complex patient discharged, from where, what medications possibly were they discharged from. My patients would most likely say, well, I was discharged on Friday night. Nobody ever arrived from home care, but I didn't know who to call. My medication list, I really don't know what I got. So I'm trying to get a hold of someone at the hospital and nobody knows. So then I need to wait until Monday until I get a hold of my family doctor. And I think that stopped, I hope, for some of our complex patients. And for me trying to coordinate care for these complex patients who have a very strong attachment and know that when they need care and all fails, they'll come to their family doctor, but I don't even know what's happened.
Great, thank you. Good. So
That was a really good point, I have to say. When I was caring for my grandfather, whenever he had an event, let's say a fall, discharge, whatever, I had a list of 5 people, not including my parents, that I had to call or other family members. So that was at least a 10-minute conversation, giving them all the information they need and require to do their work. So that's almost an hour of billable time between 5 professionals. And I mean, that's an hour of my time as well.
Yeah.
So that right there, in conjunction with what you said, thank you very much, is a huge saver in the system.
Great. So I just, in bringing the session to a close, I thought first of all, of course, we'll give a big thank you to the panel. But I had two quotes that I thought really characterized a little bit about what we've heard today. The first is that leadership is not so much about technique and methods as it is about opening the heart, about inspiration of oneself and others. Great leadership is about human experiences, not processes. It's not a formula or program. It's a human activity that comes from the heart and considers the heart of others. It's an attitude, not a routine. And I think that message came through very strongly from all from all of the panelists today. The second one is the classic Peter Drucker quote, which is, "We greatly overestimate what we can do in 1 year, but we greatly underestimate what is possible for us in 5 years." And I think this is an exciting time around HealthLinks. To the little tug on the sleeve, just give us a little bit more time here. I think that we've heard some inspirational stories today about the progress that's being made. So we'll look forward to seeing where this next part of the journey in HealthLinks takes us. So thank you very, very much to all of our panelists. I really appreciate it. And thank you to all of you for your participation and your terrific questions. Have a great afternoon.